Hello, this is John Kanelopoulos from our office here in Athens, Greece. Very pleased to share with you this 56-year-old male who had a cornea transplant in the US in 1992. It's been 28 years, significantly visually debilitated due to very high astigmatism. This was called recurrent keratoconus. Look at the graft host interface inferiorly. You can see that the dehiscence, he's obviously an avid eye rubber. We've described this before. The solution here is not a regraft, nor is it cross-linking, nor a refractive procedure. The cells, it's been almost 30 years, guys, and they're pretty good. Topography gives us keratometry in the 60s. And you can see the area of dehiscence is bulging out, is steepening the cornea, and the significant flattening superiorly. So this is not recurrent keratoconus. Some of you may had seen it in the initial pictures. He has a significant cataract as well. So here we are in the operating table under peribulbar anesthesia. Our 275 blade, the major main incision, and then using the same blade to perform a 1mm paracentesis and go in, do a continuous curvilinear capsulorhexis in a standard technique. Obviously, the challenges in doing cataract surgery in a grafted patient are the reduced visualization at the 8mm diameter. But the tricky thing here, and this is common in keratoconic eyes, I want to stay here and share this with you, is that during the capsulorhexis, I'm getting the feel that the whole capsular lens complex is moving too much, similar to a unstable capsule in pseudoexfoliation patient, and more so here when I'm performing my hydrodissection. I'm pretty much frozen because everything is moving. You can see the jerking of the lens. It's moving 1 or 2 millimeters. So I'm panicking. I'm making sure that my retina guys stand by in case this whole baby drops in the fundus. And here we are. We can see that even at this early age, the cataract is quite hard. We are using a standard divide and conquer technique, no fancy stuff here. And you can appreciate what I mentioned before. See how the lens springs in and out, and how there's increased mobility of the lens capsular apparatus complex. I'm able to crack this lens relatively straightforward. You can see that the pupil is coming down a little bit. We're going to use some diluted epi to bring it up again. Fortunately, everything here goes well. Crack in 4 pieces, and here I am removing the last quadrant. In order to protect the cornea that has survived 30 years on this host, I've used Viscoat several times to cover the cornea endothelium, which, by the way, I feel that after 3 years is excellent for a graft. So we can see now that the capsular bag is pretty stable. It's probably the zonule ring of the sclera that's so soft and rubbery. I'm removing the residual cortex here with my magic split instrument to get the cortex under my main incision. And the tricky part here is, of course, IOL calculation. We saw the keratometries before on Placido disc topography that they were in the 60s. We are looking at the actual length measurement here, 26.33. So this fellow, if he didn't have keratoconus, he would be about a -6 myope. A lot of calculations here. We have to go to our past experience of resuturing grafts and looked at the numbers, and our average is about 45. So we used an arbitrary 45 keratometry in our IOL calculation, and thus the 11 diopter lens that's implanted here, as we're expecting the keratometry of 60 to flatten with what you're going to see we're going to do now. Of course, I did the cataract first because I wanted to take advantage of the better visualization before I go in and suture the inferior part of the cornea. I'm placing, this is an IQ Acrosoft lens. No toricity here, as we have no idea how we're going to end up. Due to the cone and the very rubbery cornea, I have to put a mattress suture here. And here I'm using my keratome to reopen the graft host interface, which, as we saw in the first pictures, has a humongous step and is ready to basically open up. I'm going to have a micro perf here at some point, but I'm trying to release the graft host interface in order to create a new one by resuturing the cornea in the inferior part, but as we will see, I'm going to put some superior sutures to create balance in my resuturing. I'm not going to put a total of 16 sutures. I think that we're going to end up with 12 sutures. And plus this reopening of the wound will help to create, see how rubbery the cornea is here. This patient is an avid eye rubber. I spend time and over again explaining to him that he has to stop eye rubbing even at bedtime or during sleep. See how this cornea is so rubbery. The graft cornea and the host, I'm using very long bites on my sutures, and we are here using what would have been the horizontal cardinals. You see I placed at 12 o'clock, and here we're starting to use riboflavin solution, and this is kind of a prelude of what's going to follow. You can see that I'm suturing tight because we want to flatten this 60 diopter ectatic graft host interface cornea. And as I mentioned before, I'm going to use some of the superior sutures. We're using Vibix Extra. This is the 0.25% riboflavin solution, almost 3 times more than the standard by Vidro. And the last 15 minutes of my suturing, the surgical assistant is going to be instilling. I'm replacing my first suture at 6 o'clock. This is obviously surgeon's view, so we're seeing it at 12 o'clock because at the end of everything it was kind of too tight. And again, very careful here to grasp as much as the host bed I can to create a scaffold of scarring. I'm rubbing as much as I can the epithelium to create the penetrance for the riboflavin solution. As I mentioned before, a solid 15 minutes drops every minute. The graft and the host cornea are yellow in tinge, and we're going to use the KXL1 device set at 10 milliwatts per centimeter square for a total of 7.2 joules irradiation of UVA to generate cross-linking. Here are some of the sections with OCT showing how we're able to reapproximate the cornea and reverse the extreme ectasia. The patient was recommended elsewhere by many cornea specialists to be regrafted. I think that this is a better solution. If the cornea fails, a dissect will be a better option. Hope you found this case interesting. This is John Canalopoulos. Thanks so much for your attention.